Good afternoon, everyone, and welcome to our 2022 Emerging Scholars talk at the Philip R. Lee Institute for Health Policy Studies at University of California, San Francisco. I'm Janet Kaufman, Co-Associate Director of the Institute for Policy and Programs. The Emerging Scholars program is an exchange program for early career health services researchers at UCSF, University of Michigan, and University of Pennsylvania. And so it's an opportunity for emerging scholars at these three institutions to visit their sibling institutions, share their research, network with scholars who have similar interests. This is a return. This is our actually third year. We took a hiatus last year for the pandemic, but we're back, and this is our first experience with a hybrid approach. So please bear with us, those of you that are out there in our Zoom audience. It's my pleasure to introduce our speaker for today, Dr. Paula Chatterjee of the University of Pennsylvania. Dr. Chatterjee is an assistant professor of medicine in the Division of General Internal Medicine at University of Pennsylvania. She holds an MD from Harvard, completed her residency in internal medicine at Brigham and Women's Hospital, and also holds an MPH in chronic disease epidemiology from Harvard. Her research interests include hospital and post-acute care quality, alternative payment models, Medicaid policy, and the healthcare safety net. And that last bit, the healthcare safety net, is her topic for today. And I think if we've learned anything in the COVID pandemic, it's how fragile the safety net, how challenging access to appropriate care can be for the lowest income, most diverse among us. And so I'm excited to hear what Dr. Chatterjee has to tell us about how we could reimagine this safety net for the most vulnerable. And with that, Dr. Chatterjee.
Thank you. Thank you so much, Dr. Kaufman. Thank you, Beth. Thank you all for being here today. And for those of you on Zoom, I'm so grateful to have this Emerging Scholars program because I think it's rare to find these kinds of opportunities for junior faculty. So thank you so much for putting it on. I really appreciate it. And it's great to be here. I'm really excited to share some of my work today that relates to the healthcare safety net. Just some disclosures, a subset of some of the work that I'm presenting to you today is funded under my K-23, which is from the NIA, and also there are some projects related to work funded by the Laura and John Arnold Foundation. So like many of you either in here or in the audience, I spend a subset of my time seeing patients. About 80% of my time is spent as a health policy researcher, and 20% of the time I'm practicing medicine at Penn Presbyterian Hospital, which is pictured here. Presby, as it's affectionately known, is located in West Philadelphia, sort of at the periphery of the city before you get into deep West Philly. And for the patients that we take care of, Presby is largely seen as their community hospital. You know, the patients will fondly, albeit maybe a little morbidly, say, you know, I was born at Presby and I'm going to die at Presby. And that's sort of the mentality that they have and some of the fondness that they share for this institution. What I will say is that our health system recently built a brand new building on the campus, which is beautiful and lovely. This is located less west in Philadelphia, but it's it's 1.5 million square feet. It's 17 floors large. It has 504 private patient rooms. And when it opened, a couple of months ago, we were all very proud to say, look, our health system is still standing after sort of weathering the pandemic, which we continue to, of course, weather today. However, while the health system might have been learning how to survive and perhaps thrive in sort of the COVID area, in the COVID era rather, I will say that the rest of Philadelphia has been having a harder time. So for example, job loss has recovered to some extent nationally, but the pace of recovery in Philadelphia is a bit slower than that of the national rate. For students, we're just seeing the beginning of some of the consequences of disrupted school, and already there's some evidence showing some undoing of some of the closures and the racial educational gaps that we've spent decades trying to achieve. And then, as many of you are likely aware of the fact that crime in Philadelphia is sort of beating records for all the wrong reasons. And this year, we're actually on pace to beat ourselves from the record we'd set last year for the most homicides in the country. And so I think I present sort of these two worlds that I think many of us live and breathe and work in, where we are lucky enough to work in these thriving medical centers, but they're embedded in communities that are continuing to struggle and grapple with the structural determinants of health. And so all of this has really got me thinking a little bit about what it means for a hospital, a health system, a larger university to interact with the community in which it lives. And this is sort of the broader concept that undergirds what I'm hoping to talk to you about today, which is really trying to build an evolving understanding of the relationship between healthcare systems and the patients that they serve. And particularly for low-income patients, that's really where my research focuses. So this is obviously a complicated thing to talk about, but I've chosen to simplify it into some of the issues that I think are most within the grasp of the healthcare system. And perhaps we have existing expertise to address these possible levers as ways to improve outcomes for low-income patients. So, for example, I think the healthcare system is well suited to improve access to care, improve quality of care, and, as we're learning, to potentially address some of the structural determinants of health. And so I think of each of these as levers that we can pull. And I'm going to talk a little bit about some work that I have done that contributes to these domains in different ways. And then work that I'm hoping to contribute in the future. So down here, I'm going to start today's talk by discussing how access to care for low-income patients in the United States is both concentrated and segregated. We'll then talk a little bit about sort of differences in quality between safety net institutions and non-safety net institutions. And then we'll examine the relationship between health systems and how they interact with low-income communities. And so this is all work that's sort of been done. And then in these sort of yellow boxes, I'm just going to touch upon briefly some work that I'm hoping to do in the future. And so we'll get to it when we get to it. But to start, we'll talk about access to care, which is something that Dr. Kaufman brought up right at the outset here. So what I will tell you is that the healthcare safety net in the United States is distributed across the care continuum. However, safety net as a term is largely uncodified. There is no universal definition that either policymakers or researchers can use when we're talking about who the safety net is. What I will tell you is that we in health services research focus primarily on healthcare, on the safety net in both outpatient, inpatient, as well as more in the post-acute care settings. But we often aren't thinking about this informal network of safety net providers that includes a lot of home-based care, whether that's home health services providers or informal caregivers, as well as a variety of other safety net services that are provided both within and outside of the healthcare system. This includes things like family planning clinics, school-based health programs, and Ryan White health centers, of course. So I post this as sort of a caveat that what I focus on is typically the top of this slide, knowing that we are consciously making some important omissions there and that we need to flesh those out. The safety net spans the care continuum, but I would argue that its defining feature is that safety net healthcare delivery is concentrated and segregated in the United States. And so let's talk a little bit about the evidence for that. So here we begin to look at the outpatient care setting in the United States. In this work, we focused on to what extent care for low-income older adults is concentrated, meaning that the vast majority of care is provided by a small subset of clinicians. To identify these patients, we focused on a group of dual eligible patients. This makes up about 10.7 million adults in the US who are defined by their simultaneous enrollment in both Medicare and Medicaid. These tend to be older adults who are of lower income or younger adults who are of low income and with some existing disability. And here I just have work that the Medicare Payment and Access Commission has already done for us, showing us sort of what do duals typically look like, who is represented among them compared to non-duals. And what we know is that duals tend to be, they're more likely to be women, they're more likely to be a Black race or Hispanic ethnicity, they're more likely to have multiple functional limitations, and they're more likely to live below the poverty line. So that's sort of the patient population that we're talking about here. Beyond their demographics, there's several other reasons for why we might want to focus on duals as an important population. Prior work has really focused on sort of utilization of care among duals in terms of their hospital spending, their post-acute care spending, and their institutional care spending. And that has really resulted in labeling this population as a high cost, high cost, high need, and low resource population. Comparatively less is known about how they use outpatient care, which I think could have the potential to be an important nexus point for this group of patients. Steady access to outpatient care is associated with avoiding advanced complications of chronic disease and also potentially avoiding some of these more costlier care settings. So I sort of put this here as a broader framework of why we might be interested in how these patients in particular are getting their outpatient care. And so we wanted to study dual eligibles and their use of outpatient care. To do that, we used a 5% sample of Medicare Part B claims. We linked them to the Medicare beneficiary summary file to get information on their demographics. And then using the carrier file, we basically created per beneficiary per year counts of how many outpatient care visits are these patients having. We obtained data on physician characteristics, sort of who are the types of physicians these patients are seeing from the Medicare data on provider practice and specialty, which is the MD Pass data set. And then we collected a variety of sort of county level demographics from the sources that you see listed here on the right. And so what were we trying to do in this study? It was fairly simple. All we were trying to do is understand how duals might use outpatient care compared to non-duals. We wanted to understand if care for this population, which again is typically thought of as high cost, high need, low resource, whether their care was concentrated or whether it was evenly distributed across the outpatient world. And if it was concentrated, we wanted to know who was disproportionately taking care of them, because that sort of helps us figure out who this safety net system of providers might be. And then finally, we were curious about sort of what their surrounding communities looked like as well. And so here's what we find. Just for your frame of reference, about 20% of adults enrolled in the Medicare program are dual eligibles. And so that's where the ends come from at the top there. What we find is that duals had fewer outpatient visits per year on average compared to non-duals. And this is despite the fact that they tended to have more chronic conditions. So more chronic conditions, fewer outpatient visits. These differences in visits were largely driven by access to specialty care. So duals had fewer specialty care visits compared to non-duals. Again, small magnitude, but these were the differences that we saw. And then the differences in specialty care were sort of split between both medical and surgical subspecialties. So not a clear dominant force there in terms of explaining what some of these differences might be coming from. We then wanted to look at whether there were certain physicians and practices that were disproportionately serving these patients. And so this is something called a Lorenz curve, which basically describes concentration of care. I'll walk you through the figure. So on the x-axis, what we've done is we have ranked physicians and practices according to the share of dual eligible patients they serve. And on the y-axis, we have the cumulative percent of duals in the United States. So by the time you get to 100% on that y-axis, you're at 100% of doctors. The thin diagonal line represents what you would expect if care for duals was uniformly distributed across practices. Concavity in this curve reflects inequality in the distribution of care. And so there are a couple of things that stand out on this curve. What we found first is that about 20% of physician practices in the US don't take care of any dual eligibles. And about 80% of duals are cared for by about 30% of practices. So it's a pretty a pronounced degree of concentration of care. We then use this curve to sort of define high dual versus low dual practices. So we characterize these 30% as like high dual serving practices and then compare them to the rest to see what they might look like. And so when you compare these practices, we find that the high dual practices were more likely to have slightly smaller panels. Their patients actually had fewer comorbidities, which I don't believe I presented here, but is on a separate slide. And unsurprisingly, by virtue of the demographics of duals that we already know, these high dual practices disproportionately served Black and Hispanic adults. Again, unsurprisingly, before I get there, what I think is interesting is that high dual practices sort of have this bimodal distribution in terms of their size. They're either teeny tiny with just like one doctor in a given practice, or they're massive with over 50 doctors in their practices. And then the other thing I'll mention is that they were slightly more likely to be primary care practices instead of specialty practices. And that's aligned with one of the earlier tables that we saw in terms of the types of outpatient care that duals are receiving. Finally, and again, this is the unsurprising part, is that patients who were being served by high dual practices were more likely to live in areas typified by higher measures of structural disadvantage. They were living in areas where there were higher percent poverty, lower median household income, and a higher percentage of SNAP enrollment. What's interestingly is that we don't really see a big differences between the prevalence of obesity or tobacco use between these patient populations, but the social service use and the poverty level was higher. So taken together, I think that the findings from this study can sort of be summarized here. We find that duals, which again represents this high cost, high need, low resource population, had fewer outpatient visits despite having more chronic conditions, and these differences were largely driven by specialty care access. 80% of duals are cared for by 30% of practices, and that over 20% of practices serve no dual patients, and that high and low dual practices are different across a variety of dimensions. This is not news. I will not pretend that that is a novel contribution by any means. What I will say is that we, in the prior study, were looking at duals as a measure of structural disadvantage, but many other studies have looked at other measures and found similar patterns of concentration. So this is a study from 2004 that again created a Lorenz curve to show where the vast majority of Black patients insured by the Medicare program were being served for their outpatient care. And at that time, you can see remarkably similar patterns, that about 80% of Black patients are served by a little over 20% of physicians and practices. This is specific to the primary care setting. And these patterns are not isolated to outpatient care. This sort of 80-20 phenomenon that we find also spans inpatient care and post-acute care. So the study on top is from 2007, and it showed that 25% of US hospitals, sort of in this high and medium bucket, served 87% of Black patients, much of that being concentrated in the top 5% of hospitals in the distribution there. And in this study from 2004, the authors found similar patterns for nursing homes. And what they basically said here is that they place these differences that we see in the healthcare system in the broader context of segregation in the United States that permeates hospitals, schools, and other social institutions. I want to make note here, just to sort of be clear in our thinking and my thinking about what the differences between concentration and segregation are when we are talking about these concepts. They are, of course, related to one another. But in terms of what we're actually measuring, I think when we're talking about concentration of care, what we're measuring is whether the majority of care and services are provided by a small number of doctors and providers. When we're talking about segregation, we're talking about the clinicians and practitioners serving one group of patients being fundamentally different from those serving other patients. And segregation, of course, is the result of multiple historical measures of inequity that permeate where people live, commute, work, and that drives a lot of these practice pattern variations. What I will say is that as a health services researcher, I tend to find myself living in this concentration world just because that's what we're able to measure. But it is, of course, influenced by other measures of segregation that are rooted in historical context. I do focus on concentration and particularly what the implications of that concentration of care are for patients. And that sort of gets us into our next lever here, which is talking about quality differences between safety net institutions and non-safety net institutions. So again, just to sort of guide the flow here, I think the safety net in the US is largely defined by the fact that care for low-income patients is concentrated and segregated. And so now we're going to talk about whether those institutions are fundamentally different in terms of the quality of care they provide. In understanding the story about quality, I think it's important to mention that there's a two-tailed hypothesis here, right? So what we're trying to understand is whether that 80-20 breakdown is bad for patients. On one hand, it's possible that this concentration of care could lead to worse quality. That might be because safety net institutions have constrained finances, their patients are more likely to experience the structural determinants of health, which predispose them for adverse outcomes. And these hospitals might just have limited personnel and infrastructure that makes it difficult to invest in quality improvement. Oh. On the other hand, if care for low-income patients is concentrated, it's possible that there are some returns to specialization of care in those institutions. What do I mean by that? It might be that safety net providers have unique community level expertise and knowledge that allows them to treat their patients in a more patient-centered way that improves their outcomes. These hospitals might have strong community-based relationships that other hospitals may not have, and that might have returns to care that's provided outside of the hospital in ways that benefit patients. And then finally, I think that there is something about safety net institutions in that they are mission-based entities. And that in and of itself could be a soft asset that translates to quality improvements in ways that might be difficult to measure, but are still important. So again, I think there's a true two-tailed hypothesis here that is worth measuring. So as value-based payment movement efforts sort of took hold in the early 2000s, there were several studies that raised concerns that safety net hospitals in particular might not be able to perform as well as other hospitals on a variety of quality measures. And so on the left here, we have a study by Rachel Werner and colleagues from 2008, which showed that at the time, safety net hospitals were less likely to provide guideline-based care for treatment of acute myocardial infarction, heart failure, and pneumonia, and that their rates of improvement were smaller over time compared to other hospitals. In another early study from 2013, we found similar patterns on measures of patient experience. Now, these are quality measures that ask patients, do you feel like you received care that was in line with your goals? Did you receive discharge information? Would you recommend this hospital to other people? That's sort of what we're trying to capture there. And in that paper, we also found that safety net hospitals performed less well, and the gaps between safety net hospitals and other hospitals were somewhat persistent and maybe slightly widening over time. Both of those studies are, nearly a decade old at this point, but I will tell you that this is just sort of informal analysis of public data at this point, showing you that some of these gaps in patient experience have sort of persisted over time, albeit with not a lot of evidence of widening. Here we have safety net in the red and non-safety net hospitals in the blue. Higher scores are better on this quality measure. However, I say this humbly that it depends a little bit on how you look at it in terms of whether safety net hospitals perform better or worse than non-safety net hospitals. So this is a study where the authors compared quality between safety net and non-safety net hospitals, but limited the comparisons to being in the same geographical area. So for us, that would be like comparing Penn to Temple as opposed to comparing Penn to like Boston Medical Center. Sort of limiting geographic comparisons and potential variation that could be derived from a larger geographic source. And what they find is that, maybe there are some small differences on a couple of different quality measures here, focusing on acute myocardial infarction, heart failure, and pneumonia. But they thought that these were pretty small relative to sort of what the true means on these scores were. So given this potential sort of heterogeneous body of evidence on safety net performance, we saw this as an opportunity to do a systematic review. And so here what we've done is we have looked at 67 studies from 2000 to 2020 that have compared quality between safety net and non-safety net hospitals. This is our consort diagram where we sort of present our exclusion and inclusion criteria here. The first thing that we noticed about these 67 studies is that they take a variety of different approaches to defining who the safety net is. The majority of studies choose to define safety net hospitals as those that serve the most Medicaid insured patients, the most uninsured patients, or a hospital's disproportionate share hospital index, which is something I'm happy to explain if anyone is curious. And then studies also took a variety of other approaches and even tried to combine definitions to really capture who the safety net is comprised of. And to me, this really just sort of reflects an earlier point, which is that there's no universally accepted definition for either policymakers or researchers in terms of figuring out who these hospitals are. So in these 67 studies, they looked at 275 different quality measures. Of those 275 different quality measures, 53 of them had something to do with 30-day readmissions. And so then what we did is we just sort of qualitatively compared whether the study found safety net hospitals to be the same or better or worse than non-safety net hospitals. The dark blue bars here represent the number of studies that showed better or similar performance, and the light gray, I believe that is, showed studies where safety net hospitals did worse. And so what you can see here is that, sort of across the board, safety net hospitals appear to perform less well on measures of readmissions. And that pattern is pretty consistent as you look across different disease-specific measures of 30-day readmissions. But the story is a little muddier when you look at other quality measures. So here we look at mortality. Again, just to refresh your memory, 67 studies, 275 quality measures, 45 of those quality measures look at mortality. And we find it's a little bit more of a coin toss. When you look at mortality from acute myocardial infarction, safety net hospitals seem to do worse. When you look at mortality from heart failure and pneumonia, safety net hospitals might actually do a little bit better. And so the story is not as consistent as we might expect it to be, and as what sort of the prevailing narrative might suggest here. So there are a lot of other interesting findings from the review that I'm happy to talk about if anyone has questions. But I think our takeaway was that, out of these 275 quality measures, safety net hospitals did as well or better in about half of them. They do perform less well on readmissions measures, but I will tell you the differences were small in magnitude, sort of echoing the prior health affairs study, and that patterns were a little bit more mixed on things like mortality, although the pattern for mortality from AMI, acute myocardial infarction, seemed pretty consistent across the literature. So I think this tells us that sort of having this monolithic understanding of how safety net hospitals provide care and the quality of that care might not necessarily be supported by the evidence. And just to be clear, I think that there are a lot of reasons that we might be worried that safety net hospitals don't perform as well. And I've listed some of those reasons here. Low-income patients who are more likely to face structural determinants of health are predisposed to have more aggressive disease and poor health outcomes as a result of those structural determinants. And really, at this point, none of the current paper performance mechanisms we have are really great at quote unquote risk adjusting for that. Risk adjustment is sort of the perennial problem that we continue to deal with that makes it difficult to make comparisons between hospitals. Historically speaking, what I'll say is that many safety net hospitals in the US are remnants of something called the Hill-Burton Act, which was passed in 1946, which is the last time that hospitals were really invested in from a national state in terms of their infrastructure and technology and capabilities. So there's some concern that safety net hospitals might just be less able to keep up with the hospital arms race as we see it today. And then finally, given that safety net hospitals have financial challenges related to the amount of uncompensated care they provide, there's concerns that they don't have the resources, the bandwidth to invest in infrastructure and personnel needed to motivate quality improvement. And so I've become somewhat fascinated by this last box here, which is sort of trying to tell the story between finances and quality, and really trying to understand sort of what this whole relationship between margin and mission really is. And what it led us to ask is sort of what is the relationship between hospital finances and quality of care? Is it true that if your hospital finances improve, that your quality might get better? And in particular, is that true for the safety net? So I'm going to present a couple of studies relating to that. Maybe I'll pause. Any questions? No? Please. And I can repeat it. Yeah.
So the question is, can you talk about how these results are affected by the fact that safety net hospitals may care for folks with higher prevalence of social needs, which inevitably affect health outcomes?
It's a great question, sort of trying to understand the disproportionate burden of disease and social risk faced by patients who are in the safety net. I will say that all of the results we see are certainly driven to some extent by those social risk factors. Teasing them apart from what we can currently measure, whether it's in claims data or hospital level data, is a tricky thing. But I think that's a central point through all of this. I'm grateful for the question. Yeah.
Yeah, I have just a quick one to ask you to speculate a little bit on the access component of it. So how much do you think is the mechanism of reduced specialty care driven by like Medicaid managed care compared to like structural barriers, like there aren't specialists in the neighborhood? Like how much is this a policy choice by managed care versus the segregation aspect?
Totally. Oh, such a great question that I find myself not having a good answer to, which I will just say out front. I'm thinking of Nancy Keating and Bruce Landon's recent JAMA Network Open paper, which is looking at sort of what networks of care for networks of referral care look like for, I believe they were comparing Black Medicare beneficiaries and white Medicare beneficiaries, so not specific to the Medicaid managed care question, but showing basically vastly disparate referral networks among that patient population. I'm also thinking about Will Sparrow's recent health affairs paper, which did look at Medicaid managed care providers and sort of was finding that there's this abundance of sort of ghost providers in Medicaid managed care organizations, basically organizations that say that they can take care of patients insured by the Medicaid program, but actually serve none of them. So your point is so well taken that I think all of these are sort of complementary and interlinked. I don't know the extent to which one is dominant over the other one, though. I would love more data from managed care organizations. That maybe I'll use that for a plug. Yes.
And then just to build on your hospital finances and quality of care, I know we see just here in San Francisco some pretty significant differences in wait times for specialty appointments between the suburbs of San Francisco General, that is the safety net hospital, and UCSF, and it's really driven by hospital finances and ability to pay an adequate complement of specialists to see those patients in as timely a fashion as possible.
Totally. And it's oftentimes, by the time we are referring lower income patients to specialty care, a lot of their disease is more advanced as well. And so it's almost like the returns to early specialty care for those, quote unquote, early, the returns to specialty care for those patients might be greater, but of course are exacerbated by things like wait times and whatnot. No, it's very, so well taken on all of those points. All right, let me get to a little bit about this work on the relationship between finances and quality. So hospital finances fluctuate for a variety of different reasons. However, the Affordable Care Act, which was passed in 2010, enacted in 2014, gives us this wonderful opportunity to study what some of the consequences of changes in hospital finances are on other potential outcomes. So what I will say is the ACA was broadly good for hospitals that were in expansion states. So what I'm showing you here are that hospitals in expansion states in the blue line on the left panel. This graph shows us that uncompensated care for these hospitals declined after the ACA was passed. And if you look at changes in sort of what the ultimate bottom line was for hospitals in terms of their operating margins or total margins, that's what you can see here on the panel on the right, which is that margins got a little better for hospitals that are located in expansion states compared to non-expansion states. So this gives us an opportunity to say, hey, your finances got better. Did quality also get better? So to do that, we used data from 2012 to 2018 from a variety of different sources, including the AHA's annual survey to get hospital characteristics. We got information on hospital finances from the Medicare cost reports, information on Medicaid expansion status from the Kaiser Family Foundation, and then looked at a couple of different measures of quality of care. These are all publicly available data. So we included measures of patient experience, healthcare-associated infections, readmission rates, and mortality rates. And then we went and applied a time-varying difference in differences approach to try and understand whether quality differentially improved at safety net hospitals in expansion states compared to non-expansion states. This was just a within safety net hospital comparison. I just want to be clear about that point. And so first what we do is we confirm that safety net hospital finances in particular did improve after the ACA. And so what we find is that if you were in a hospital, a safety net hospital in a Medicaid expansion state, by about 2018, your fraction of uncompensated care declined by about 1.4 percentage points, and your operating margins improved by about 2.1 percentage points. Unfortunately, across a variety of different quality measures that I mentioned before, we didn't really see this translate into any differential improvements in quality. So this is just a forest plot of a bunch of different coefficients for different quality measures. We have patient experience, healthcare-associated infections, readmissions, and mortality rates. And you can see this is a whole bunch of null, largely. No significant improvements in quality, despite some improvements in hospital finances. We did try and cut the data in different ways. Here, we were looking at hospitals that maybe had lower baseline operating margins, sort of testing the hypothesis that maybe if you were a hospital that was a little bit better off financially before the ACA, that the financial benefits of the policy might have been more salient to you in ways that would let you invest in quality improvement, but this is also a whole bunch of null. No big differences across baseline hospital financial status as well. We found consistent findings across rural safety net hospitals as well. So the prior study focused predominantly on sort of large urban hospitals that typically serve safety net functions. Here we sort of applied the same methodologic approach, but focused on a group of hospitals called critical access hospitals, which are a key part of the rural safety net. And again, we find no big improvements, no significant improvements, focusing on quality measures that are more commonly reported among rural hospitals that we know are limited by the denominator issue in terms of the types of quality information they can provide. We tried to look at whether rural hospital staffing got better, knowing that staffing shortages are a really important challenge that these hospitals are facing. So we looked at physician staffing levels, primary care, including both primary care and specialty physicians, as well as RNs and LPNs, and again, found no big differences there. So it remains a little bit unclear to me in terms of what the spillover effects of these improvements in hospital finances were after the ACA. We can say that they probably weren't going to quality and we're not going to staffing, but perhaps they're going elsewhere. So this is just a summary of this section on quality that I will just mention here, which is that we know that there are some quality differences between safety net and non-safety net hospitals, but they might be smaller and sort of less monotonic than previously thought. The ACA did improve safety net hospital finances, but we don't really see big improvements in quality. And those patterns were consistent across both the rural and the urban safety net. So then getting back to our framework here, I'm going to talk a little bit about some ongoing work we have that looks at how hospitals and health systems are contributing to the structural determinants of health for low-income communities that are surrounding them. So one way that health systems contribute as a structural determinant of health is that they're a major source of employment. So these are data from the county business patterns, which show us that healthcare is actually the largest sector of the economy in terms of labor force. And is one of the largest contributors to the growth in wages among the labor force nationally. So there's a potential for this being an important lever by which hospitals and health systems can affect social determinants of health, acknowledging that income is, of course, one of them. We know that the healthcare workforce is comprised of high wage and low wage workers. I am a high wage hospital worker, and typically the low wage hospital workers are individuals we think about in the environmental services and the food services industry, and home healthcare workers make up a large portion of the low wage workforce here. And so this is a paper that we worked on a couple of years ago, which shows that there is an income mortality gradient among healthcare workers specifically, where the probability of mortality, if you're a healthcare worker, decreases with your income. The red and blue indicators show you that this gradient is similar between the healthcare workforce and the non-healthcare workforce. So we're not special in that way. But it could also sort of tell you that, that might sound reassuring at first, but we were actually thinking that, if you have workers who are in close proximity to healthcare resources and specialists and care, that might moderate this relationship differently, but it doesn't appear to. And so this work supports the argument. I think that wages might be an important structural determinant of health, specifically among low-wage healthcare workers. And so this led us to ask this question of whether there's a relationship between hospital finances and the wages of low-wage healthcare workers. So we go back to our drawing board. We use the same diff and diff approach that we did, knowing again that hospital finances got better after the ACA. But do we see any spillover benefits for low-wage workers? That's sort of where this paper is going. We use data from 2010 to 2019 from the American Community Survey, which gives us information on who is a healthcare worker, what their wages are, and if they enroll in certain benefit programs, like if they're enrolled in the Medicaid program, or if they get employer-sponsored insurance, for example. And then, of course, relied on the wonderful Kaiser Foundation for the Medicaid expansion data. And again, this is just another time-varying diff and diff study. And so what we find that after the ACA, in expansion states, there's a small improvement in the overall income of healthcare workers. This is specifically focusing on hospital workers because that's sort of where our financial benefits are concentrated. But the improvement is relatively small and is actually concentrated among workers with the highest levels of education. We have split this out by income. It's not quite pretty yet, so it didn't make it into this talk. But what we basically find is that all of these wage increases are concentrated in the top decile of the waged workforce, finding sort of a rather specific effect of where some of these benefits might be going. When we look at other types of benefits, what we find here is that after the ACA, healthcare workers were actually less likely to receive insurance through their employers and more likely to get punted onto the Medicaid program. This was in expansion states differentially compared to non-expansion states. And so for me, this sort of is beginning to tell a story of Medicaid expansion, improved hospital finances. Some of those finances might have spilled over into improved wages for high wage workers. And it's possible that for low wage workers, benefits of employer-sponsored insurance were withdrawn, but not actually made up for in the form of wages, and instead they were punted onto federal programs like Medicaid. We also find similar effects for food stamp programs as well. So just to summarize, improvements in finances, small increases in worker wages concentrated at the top of the educational distribution, and workers were less likely to get health insurance through their employers and more likely to enroll in Medicaid. All right. So in just going back to our framework, I think we've talked a little bit today about some of the evidence showing that care for low-income patients in the United States is concentrated and segregated across the care continuum, and that's largely the defining feature of what makes up the safety net. There are some quality differences between safety net and non-safety net institutions, but perhaps they're a little bit smaller and less consistent than we may have thought. And that when health system finances improve, we don't see much of the way of improvements in care quality, There may be some improvements in worker wages, but they're concentrated among high wage workers. And so I'd like to end today with just sort of the last 15 minutes here talking about some active work that is unfinished, but that I'm hoping to do to extend sort of each of these levers. So we'll start by talking a little bit about another dimension of access that I've been thinking about, which is access to clinical innovation, in particular on access to clinical trials. And so this has become a rather a common topic that I know many folks are exploring, but we know that there are many barriers to clinical trial participation, particularly for low-income populations as well as minoritized populations. And here we describe that those barriers sort of extend to where we make trials available for patients, how hard it is to become eligible for them, and then how hard it is to maintain participation. So multiple barriers to enrollment. One of the many barriers that patients cite is the cost related to participating in a clinical trial. And so you might be a little surprised by that. You might think like, oh, if I'm in a clinical trial, then whoever's putting on the trial should pay for me to be in that. And that's actually not fully true. There are many different ways that costs of being in a clinical trial can spill over to patients. So there are the research costs that are associated with being in a trial. That's paid for by the study sponsors. And then there's routine care costs, which involve going to your doctors, whether you need to stay in the hospital, lab tests, and imaging. And those are typically billed to your insurers. And then there's the indirect costs, right? The time it takes to go to different appointments, lost wages from taking that time to participate in this trial. And those are costs incurred by the patient. So there's an interesting policy context around trial enrollment in the US, which is that in 2000, the Medicare program began to pay patients for their enrollment costs in clinical trials. In 2010, that expanded to the commercially insured population. But notice that there's a conspicuous omission of the Medicaid population here. And in fact, only in 2020, and effective this year, now state Medicaid programs are required to cover the costs of trial participation for Medicaid beneficiaries. Before 2020, some state Medicaid programs did cover the cost of trial enrollment, while others didn't. This is work by Sam Tukborian, Carmen Guerra, and Will Shapiro, who are on the research team with this for this project. And so what we're hoping to do is sort of use this policy heterogeneity to see if state Medicaid policies that cover the costs of trial enrollment can improve some of the disparities that we see in trial representation. So no results yet, but that's active work. Another area I've been thinking about a little bit is sort of getting at some of these unmeasured quality aspects that we see in the safety net that I've hinted about a little bit already, but I'm interested in measuring what some of the specific returns to specialization might be in the safety net, be it those community-based relationships, the ability to meet patients where they are in a way that other hospitals might be less able to. And here I just sort of describe what we have chosen to measure and prioritize in a lot of our policies and what remains rather unmeasured. I think this includes things like social work capabilities or a hospital's community-based organizational relationships. We could have a whole separate talk on community benefit spending and what that means for a hospital and sort of whether there's really teeth in determining what constitutes a community benefit and what doesn't. And then I think we can also, ask hospitals to sort of measure their within hospital disparities as opposed to relying on some of these cross-population disparities that are a little less relevant to them. And so we have two ongoing projects in this area where we're trying to get at some of these returns to specialization in the safety net. One is looking at like a patient switcher model that I'm happy to talk about if anyone is interested. And then also trying to get a better understanding of what does it mean when a hospital allocates their community benefit spending. We're sort of diving deep into IRS 990 tax forms, which actually include a lot of information on all of these things I've listed here in terms of where does that community benefit money going. And so trying to really understand what they're doing, I think is a good step one. And then I'm going to end with a little bit of existentialism, which I apologize for, but it's somewhere that I find my head at the end of thinking through these issues. And I don't know if anybody is a fan of The Good Place, which was a show that was on a couple of years ago, and they talked about this text that's called "What Do We Owe?" or "What We Owe to Each Other." And I find myself thinking about this question as it relates to hospitals and health systems. Sort of what should we reasonably expect a hospital and a health system to owe to the patients and the communities around it? And that's not a fundable question, I know, but I do think it's sort of at the heart of a lot of goal setting and priority setting for where all of this really good energy around health equity in the health system can be targeted. And so these are just some of the existential questions that I find myself thinking about and not having good answers to, which is that, what should hospitals and health systems be doing with their profits? I've just presented a whole, set of projects looking at what happens when hospital finances improve. Do we see spillovers for communities or workers or quality? But maybe there's other dimensions that we need to be thinking about. And, traditionally we've thought about sort of nonprofit hospitals and health systems differently than for-profit institutions, but perhaps they're becoming more similar than they are different. I think another question that I find myself thinking about is, when should hospitals behave differently from other industries? Should we have different expectations of them than other for-profit industries that we typically think of? And then the question that always sort of comes back to me is, how much should hospitals and health systems be rewarded for subsidizing clinical innovations that affect the world and the population? I think about this at Penn, where we're lucky to have an investigator develop the mRNA vaccine, which has, changed the lives of many people. And perhaps that's one way for us to think about the role of the health system, and sort of how the health system should be rewarded or not rewarded. But understanding what the bounds of that are, I think, is something that will be important. And as we close sort of on this section, I want to put this question out there in terms of sort of defining what the roles of hospitals and health systems should be in the structural determinants of health. This issue was really sort of made plain to me in reading this viewpoint that came out a couple of years ago in 2020, which sort of asked the question of, where should hospital investments be going? And so I'm just going to read the section to you. They say, although patients are better off if hospitals spend surplus dollars on housing rather than marble lobbies or salaries, you might consider an alternate scenario in which those dollars are instead put into patient pockets and government budgets. Would there be fewer homeless patients? Would disparities in health be narrowed? They talk about the role of hospital prices in driving a lot of the spending that we see in the healthcare industry. And maybe those serve as other targets for us to think about how we might be able to improve the social determinants of health outside of, directly addressing them with purchasing housing and making other investments. So I leave this here just as food for thought, and something that I find myself thinking a lot about as well. As I wrap up, I just want to thank a wonderful team of mentors and colleagues and students who have really been wonderful and make this work joyful. And I'm happy to take any questions. Thanks.
Much. I can't make other questions. Do you want to just encourage me with the questions?
Oh, yes. Please feel free to put questions in the chat.
I guess maybe so
Please.
a comment question. And so when I saw what you found about wages and the impact of wages, it's certainly disheartening, but in my mind, not so surprising that the benefits are accruing to the most specialized labor. And so I think another, interesting question would be, if you were to look at environmental services workers, a group of food service workers who could be employed across a variety of industries, are hospitals similar or different from those workers? And I think if they're similar, my hypothesis would be that maybe what hospitals' choices about wages for those workers are being driven more by local labor market conditions.
It's a great point. I'll just say the point was in reference to sort of how hospitals might be addressing the wages of low wage workers differently from those of higher wage workers. The other thing that I'll just build on that is that a lot of low wage workers are employed by contracts and contractual arrangements that are sort of independent of the hospital and the health system. So one of the things on our to-do list is try and tease apart sort of when is the salary, wages, benefit structure determined by the hospital and the health system versus when is it determined by these other sort of contractual organizations?
Yeah, I was gonna say a similar thing. I assume that physicians have more market power, you can demand a higher percentage of that. But I wonder if there's an impact of the ones who are employed directly by the hospital. And I wonder if there are hospitals who employ a unionized workforce or parts of their thing, whether they have more capability to negotiate for more of the windfall. I don't know if you get data about that, but
totally no.
And we do know there's a lot of variation. System out here like Kaiser, where yes, there definitely is some contracting out, but there's a heavily unionized, workforce, across the board.
Yes.
So that would be an interesting additional set of research that could be done if you get the data.
Absolutely. There's been some exciting work on the role of unionization in nursing home outcomes recently, and sort of how that has shaped the pandemic response a little bit. And so that it would be extremely valuable to sort of apply that same framework to hospital workers and as well.
I guess on your quality measures, I guess in looking at that, I guess it's great to have a large list of measures, but I wonder, if there's also that going back and thinking, which of these are the measures that are most closely linked to a change in finances? And so when I think of, something like QMI, something where having the latest technology, access to latest technology can really make a difference, that makes sense. When I look at the outcomes that are around communication, I think Linda, your primary prayer with Linda Aikens and others, where nursing, there's a lot of this about nursing and work environment, how people relate to each other that are less about finances and more about organizational culture and climate.
Totally. No, this point about sort of what are the most proximal or addressable quality measures when hospital finances improve. We ended up relying a lot on the qualitative work from Betsy Bradley on sort of how do you improve readmissions. And they did all this great qualitative work showing, well, if you can hire a discharge planner, you can reduce your heart failure readmission by about like 0.4 percentage points, relative to, other hospitals that they had there. And that was one way for us to sort of conceptualize magnitude. If I can see X improvement in a margin or X reduction in uncompensated care, what is a reasonable thing to expect? Things like mortality never move, measured from the hospital standpoint. So we were less surprised about that. But your point is well taken. And this point about the MI quality measures is something I've been thinking about as well from our systematic review, where we found on measures of acute myocardial infarction, there was sort of a more consistent pattern in safety net hospitals performing less well. And maybe that's exactly for the reasons you mentioned. It's access to a cath lab, it's access to, an interventionalist, whereas quality differences on measures for heart failure and pneumonia, which are a little bit more standardized, a little bit outside of the technology domain, were much more muted.
Heart failure, diet and taking your meds.
Yep.
Outside of the hospital are two key variables.
Right. I can diurese just as well or as poorly as the next guy when they're admitted to the hospital. But no, exactly.
The difference between the process measures and the outcome measures, that they're directionally different, makes you wonder how much of quality as measured by these process measures like readmissions is big academic medical centers or integrated delivery networks employ an army of coders to make sure that they don't have, it's basically just making sure the denominator is tweaked to the ideal percentage that hospitals don't have.
Totally. No, and this is something that AJ and I were talking about earlier this morning, which is sort of like this, the role of the administrative workforce in hospitals as sort of like a tool for quality improvement, but also a tool for improving finances is something that I think is really interesting. And we know from like a variety of work that, in response to participating in value-based payment programs, we just see a lot of upcoding of things, like we see a hefty coding response a lot of the times. And whether safety net hospitals have the same resources administratively to do that is something I'm very interested in. I wonder if it's no, but yes, yeah.
So one question in the chat from Paula. I'm interested in your thoughts on hospitals and other organizations' ability to accumulate enough wealth to actually invest in housing and the ability of individuals to use that money through somewhat lower prices, much of which go to insurers and only indirectly to wages.
Can you say that one more time?
Yeah.
I'm so sorry.
It's okay. I'm interested in your thoughts on hospitals and other organizations' ability to accumulate enough wealth to actually invest in housing versus the ability of individuals to use that money through somewhat lower prices, much of which go to insurers and other indirectly to wages.
It's a great question. Sorry, I'm was just reading it myself. I think it's a great question, sort of how much hospital wealth can be translated into investments in the community versus sort of getting some of those resources back into the direct pockets of folks in the community. There's a lot of interesting state level experimental work going on here. So for example, in New York State, their Medicaid program has something called a DISRIP that I'm happy to talk about if anyone is interested in. But it's basically a program where they're trying to improve the relationships between health systems and community-based organizations, and seeing if that is a reasonable financial strategy for them to address some of these structural determinants. Initial evaluations of that program seem to suggest that when hospitals built these relationships, what happened initially is that the number of patients funneled to those community organizations increased, but quickly overwhelmed their capabilities because it didn't come with sort of a commensurate supply of resources to manage the increase in demand. I don't know if this gets exactly at this question of sort of what is the best way to improve structural determinants in a way that's meaningful to patients in the most direct way. But I'm reminded of that as just like one example from a policy standpoint of where there were sort of these pleiotropic effects. We thought that by just building these relationships, we would be able to improve some of these outcomes, but it was a bit more complicated than that. I'm happy to finish early and give folks a few minutes back too. Thank you so much. I really appreciate the time.